and you wrote it, and then you use it like a joint from Wikipedia, of course. And then he also have a history of addiction to alcohol and smoking, which he stopped the alcohol for the last 4 years and smoking for the last year after the diagnosis of lymphoma. The rather interesting thing is he has a family history of schizophrenia. His younger brother has had schizophrenia. He also has cardiotoxicity from chemotherapy, a low EF. What else? And then we decided to talk to him about treatment objectives. The treatment objective for this patient, for this gentleman, is to control his pain, nausea, his appetite, and correcting his insomnia. And of course, improve functional by improve his sleep quality. And of course, we do treatment alliance with him, and we also try to confirm the patient's commitment to the avoidance of the use of street cannabis in the first phase. That's all we have for the first group. Thank you very much. I thought we do treatment plan later on. Shall we do it now? Or do you want me to tell you now?
Yes.
We want to tell you now, okay? We actually decided several options. We were thinking back and forth between THC or 1-to-1 combined, but we think this gentleman has been high on THC for the last 20 years, so we think something milder and slower would help. So we think if he chooses to, of course, it depends entirely on his decision. We will discuss this treatment planning with him and his family members. They're there. And if he agreed on cannabis, we would recommend the use of combined 1-to-1. Start from a low dose, of course. 1 drop every 3 days, is it? and then the second option is he don't have to take anything because he's been so high on joint for the last 20 years. He probably used other things like psychological intervention and other things. This is my makeup.
Okay, so I think we had a good understanding. Before we make some comments, as yes, we would like to know from the group.
Group.
From everybody. Actually, you know what? How about we have the other group presenting before, and then we have a discussion. So let's go.
So from group 2, all the histories the same as group 1, so I will skip this part and start with how we assess this patient. So first we start with the physiological status. We think about the symptom of nausea vomiting, that nauseative pain and appetite, anorexia, fatigue, dyspnea, insomnia and somnolence. So the second we access the functional status. His ECOG is 2 to 3. That seems to be he really big number. And third one we think about the mental status. He has anxiety disorder, depression, from his social history that he break up with his girlfriend and he has no suicidal ideation. So, and the fourth is the medical status. His current medication, he has no allergy to any medication and he's on Ativan or lorazepam for 1 milligrams per day. And he's on chemotherapy. And now he used street cannabis since he was 13 years old, and it seems he has a cannabis dependence history. And he denied history of psychosis or his he denies schizophrenia, bipolar on his own or his family. No other drug use abuse. So we think about treatment plan. First of all, we would like to treat the depression and anxiety first because from the history, he denied all the conventional, conventional treatment. So we think it's from his depression, so he has poor judgment. Okay, we start with depression and anxiety. So we consult to the psychiatrist and think about the restart the Celexa or antidepressant drug again. And for nausea and appetite, we will continue his anti-emetic drug. And then we think about titrate THC-rich oil, like 3 drops per day or 1.5 milligrams in equal TID dose. And because he is a street cannabis abuse, so we think about reduce the dose of his street cannabis, maybe 3 days, every 3 days. Because you don't know what is exactly component of the street cannabis. So maybe just wait and see. Increase every 3 days and just wait and see of the side effect. If there is a side effect from decreasing, maybe just wait and see the prolonged decreasing time. Okay. And for insomnia, we think about, because it's all the initial insomnia, it's about a problem of ability to fall asleep and the maintenance of sleep. So for the initial insomnia, we think about increase the lorazepam dose is a short-acting benzodiazepine to shortening his initial insomnia, so it's for easily to go to sleep. And we think we have titrated the THC-rich oil already, so it can benefit to maintain his sleep all whole night. Okay, and then we follow up, monitor the side effect because this patient has a score of somnolence 9 from 10. So we will monitoring the somnolence and dry mouth and oversedation. Yes, and assessment, reassessment is asked again.
Good.
อื่นๆมีกลุ่มอื่นๆมีอะไรจะแอดออนหรือว่ามีไอเดียการรักษาที่แตกต่างไหมคะ As for our group, if there are any addition comments or something,
So, yeah, we need to set up the last one. Now, I have, maybe I can, while you're preparing this, I can make some general comments, okay? What you say? No. Okay. It's all.
ต่อเข้าคอมไปไหน
Okay.
this was not an easy case. We discussed a lot as a team what will be the best plan for him, and I was a lot involved in telling, please don't let this patient go, do something to help him. I was a chemo nurse in the room, so I know the patient from the previous cancer, and I know that he was doing great. And right now, all the situation that he was going through, and so it's not a conventional case, and we offer the psychosocial support, and he clearly refused. But for sure, he will be followed during the stem cell transplant with the psychiatrist and the psychologist. So we are facing a time delay too. We are the end of October, and he's going in January for stem cell transplant. The oncologist referred us and to have our opinion, because he was really scared about the use of cannabis for this patient going through a transplant. So hashish that he is using can be mixed with any kind of thing. We really don't know. It's like a black paste. So this is the scenario of it. So this is for this afternoon. It was an important thing. So what is the important situation that we see in this case? Is a young man, 2 diagnoses of cancer in the last year. So a big change for him, and a big change in his functional status. To a fitness trainer to almost bedbound patient. Very difficult for him to tolerate the chemo. History of anxiety, and so the nausea related to the chemotherapy, and really difficult for him to tolerate this treatment. He said, my first treatment went so well, I cannot imagine that what I am going through right now. So it's a lot of context in this situation. So went back to live with his parents, not able to work anymore, not able to work out that he enjoyed. So everything was not helping his mood, for sure. And it was a really difficult first assessment. He was really on the defensive, and not refusing a bit the help, because for him it was thinking that to seek help or to use medication would be that he will be more sick than. So patient is very symptomatic. So diffuse abdominal pain, insomnia, nausea, anorexia, anxiety, and depression. And the possible contraindication with this patient, he has related with schizophrenia. We see that he's an ex-smoker, he has a history of alcohol consumption, and he's smoking cannabis for a while. But right now that he's using his cannabis, he has less benefit from it. I'm feeling unwell after smoking, and it increased my nausea. So here we are facing a case of harm reduction. Really. It's a typical harm reduction. So the patient that goes through the chemo and will go through transplant, and we will not be able to consume his hashish or cannabis during the hospitalization. So, and we offered a lot of complementary approaches that were refused by the patient. So we went through like a therapeutic alliance, and we said, if you agree to stop your street consumption and use medicinal cannabis, and you have improvement, you will have to go with our program of cancer rehabilitation, so to meet an occupational therapist, a physiotherapist, a doctor, a nurse, that will help you to go through. So finally, after a long interview, he said, okay, we'll go from there, I will decrease and I will use the cannabis as prescribed, and after that I will join, after my transplant, I will join the cancer rehab. So what was originally the plan in Canada was the Nadolol, because to a little bit decrease his need of smoking cannabis. But here we changed what we have, so we think that a 1-to-1 oil twice a day to minimize the need of smoking joint and diminishing the addiction by not immediate release, and by adding CBD to counterbalance the psychoactive effect of THC. And we asked him to slowly stop his street consumption and then to switch to medical dry cannabis strains. It was not an abrupt saying that you stop right away. You cannot, because it's too difficult for the patient to change completely their consumption. So it was at least to start with an oil and then to slowly change. But all that the idea are very good that you mentioned, and there's no good answer, but we will see with the follow-up if it has helped me. Any comment?
What's the initial dose if you recommend this as, because it's just a professional user and this one? What kind of dose?
So yes, I followed this slide. So because we start with Nadolol, we start for 7 days at a higher dose to have like a good dose for him of THC. So here we are talking about 5 milligrams of THC with 5 milligrams of CBD at night for 7 days, and twice a day for 7 days again, and then in the morning and increase only at night for 7 days. It was to be ready, like to have a follow-up within a month with us and to see if he's ready for the transplant and with the plan. On the medical document, we put limitation to THC under than 12%. So the patient cannot buy any strains of THC that is more than 12%. Any comments?
So for the case that have experience of user, you rarely start from 5 milligram at initial dose for every case, or it depends on each case.
Yes, it's true.
So that's very, very nice, and I have to say, only the presence of a nurse, and a nurse like me, would really help this condition, which I have to say would have been a bit more, for me, a bit more oriented on harm reduction versus a more compassionate approach that I think Virginie had with him. Now, first of all, we can't use CBD only in a patient that has used THC all his life. Okay, so that is a good, and there is no way that we will be able to use. However, the CBD may have a big anti-anxiety component, which is dose dependent. So it's not like with THC that is a biphasic effect. At times, if you increase too much the dose, it will increase the anxiety. CBD is not like that. CBD, the more you increase it, the more anti-anxiety you have. So in this patient, we had first to move away from that short rewarding recreational style of using cannabis, okay? But we had to do it in a way that we would not have discouraged the patient. So from going to paradise to hell, okay? Because we would have lost him, okay, very quickly. So we had to do a more progressive transition. Now, Nabilon also has the advantages that is paid by the government. This guy is certainly not rich, okay? He's out of work, lives with his parents, situation. So you have to kind of put that in the context. But in your situation, the combination of THC with CBD in an oil format will be the best harm reduction alternative to Nabilon, okay? However, don't forget that these type of symptoms are not stable over time. So you need to give a patient always access to a dry product or something that has like more quick effect. So, and the other thing that is important, even if we use a inhalation or dry product which has a potential again for addiction, but we are adding CBD to the THC. Okay, so that is another form of harm reduction. Okay, so that has been the with a Nabilon, okay, we would have anyhow giving him something quick action. Now the dry product in Canada is the cheapest available product. Okay, between dry, oil, capsule, and spray. Okay, so this is the sort of the range, but the more you go through this range, the price becomes higher. Even though spray now are a bit cheaper, but capsule are very expensive, at least 30% more expensive. So the dry is the cheaper, 30% more expensive is the oil, 30% more expensive is the capsules, okay? And the spray sort of is around the capsule cost. So, and the other thing that is important too, and that is why the medical document is a very important document, is that we have limited the THC content, okay? So this is another way to reduce the harm, because we want to gradually decrease that addiction. Now, I don't remember very well the patient, but this would be a very high risk of addiction and also of cannabis use disorder. So probably it is because of a dose or because of a compulsive way he was using it, and obviously. So I was actually told that he could recognize an addiction. So you can imagine how that, was true for him. So that is like opioid use disorder. So it's the same problem, and so you need to help, but help in the proper way. This. Do you have any question?
How do you help with the addiction of joints? How do you stop them? What is titration rate on the joint?
So it was to decrease his consumption. So he was smoking like 6 joints of hashish. So when he was stopped oil, he decreased it. At least one by one, or we try to tell them to decrease by half, but they they have to be like very honest with us and tell us. So we try to be at least sometimes flexible. Yeah. So if the type of case that is not easy.
So you ask him to do a diary of some form to make sure that he's honest on reduction of use of drugs.
So we were not drastic on telling you have to stop in 3 days to your hashish consumption. You said when you will start, you will slowly decrease the number of joints that you are smoking until you stop. So we didn't give him like a real plan for that because it was not the day of the discussion, but otherwise we can, if the patient is finally agree to the plan, we can say to him, next, as soon as you start, for the first week you divide by 2 your joint. So you are smoking 6, you will smoke only 3. Then on the second week you must have been able to stop completely, or otherwise on the third week. But when you come back, you will have switched completely to the medical. So yes, 3 weeks.
Yeah, just wanted to make so patients who switch from street to medical will recognize a better quality of the cannabis product. So they will say it works better for me, okay? Because that is the whole point. When you buy street products, one batch is good, the other one is not good, there is all this kind of...
20 years of fake drugs.
Yes. So, but that is also important to remember. We can reduce the dose also because we are using a better quality product.
And regarding this schedule of the stem cell transplantation in January, do we need to stop the cannabis sometime before, or you can continue until the...
Absolutely. We have to be careful with some medication, like antifungal, for instance, because they work on the P450, so you have to be a bit... But they are feeling so sick during the stem cell transplant that they really need something. Obviously, in the hospital, smoking or vaping is really not very much visible. However, these patients are in positive pressure rooms, okay? So theoretically, they can vape.
In the transplant ward, you cannot smoke anything, or it's only the palliative care floor that is authorized at the MOHC. But in the transplant and all the chemo, it's completely, even if you are in a negative pressure room, with the risk of contamination for the other, it's not tolerated. So he will not be able to use his product, and because the risk of contamination are very high. So that's why the oncologist send it to us to have help for him to stop that before the transplant, because he's at high risk of infection and withdrawal.
มีคำถามหรืออะไรนั่นนะคะถ้าไม่มีจะขอสรุปเคสนี้นะว่าในที่สุดเขาทำอะไรกันยังไงคือเคสนี้เป็นเด็กอายุน้อย ที่กำลังจะต้องถูกทำทรานสพลานต์ในเวลาไม่นานแล้วองโคโลจิสต์ก็หนักใจเพราะเขาต้องการให้หยุดแคนาบิสนะคะทีนี้คนนี้จากการที่เขาสูบไอ้กัญชาใต้ดินมาเป็นเวลานานไม่ให้เขาโทรลานกับ THC ทีนี้เคสนี้ก็คือพยายามต้องให้เขาหยุดไอ้กัญชาใต้ดินนะคะทีนี้ที่เขาสตาร์ทเขาก็ให้แนะนำเป็น THC CBD นะคือเขาบอกว่าถ้าถือสมมติว่าคนไข้เคยใช้ THC มาก่อนเป็นเวลายาวนานเราให้ CBD อย่างเดียวไม่ได้นะก็ให้2อย่างแล้วขณะเดียวกันก็ให้เขาลดกัญชาใต้ดินลงทีละน้อยนะแล้วเขาก็พูดถึงการแอดดามิโลนเข้าไปด้วยเพราะว่าดามิโลนในต่างประเทศเนี่ยมันอยู่ในระบบสุขภาพก็ไม่ต้องเสียเงินแต่คานาบิสออยล์เนี่ยก็ต้องไปซื้อซึ่งราคาค่อนข้างจะแพงเป็นเคสนี้เขาก็ใช้ทั้งนาบิโลนด้วยแล้วก็ใช้1 ต่อ 1นะแล้วก็ค่อยๆไตเตตโดสขึ้นไปมีอะไรจะถามหรือมีอะไรเพิ่มเติมนะคะถ้าไม่มีเราจะไปเคสต่อไปนะคะ Okay, then we go to the second case. The patient เป็นไทยหรืออังกฤษคะอังกฤษถ้าไทยพี่จะหาอาจารย์ไปแปล So we can start with the case with the guys who have 72 years old. Assessment physiologically, he comes with multiple myeloma with osteolytic lesion with history of pathological fracture at left humerus. And he has peripheral neuropathy, which is chemotherapy-induced peripheral neuropathy at his feet, and hypertension and essential tremor. His function, he's kind of good sleep quality, easy sleep and maintain. But the thing is that he wake up at night by pain. He gave us pain score 2 out of 10, which is worst pain score 2 out of 10. Average pain score is 2 out of 10, and now pain score is 1 out of 10. And somnolence score is 1 out of 10. For his mental, there is no anxiety. ECOG was 1 to 2, and medications current right now is levodopa, amidronate, and gabapentin over 1,200 milligrams each day. The past history, he has history of use cannabis before, and he used Nabilone before sleeping and make him sleep 4 hours and then waking up every 2 hours. So from now on, I think like after we took history from him, we found that even he gave us 2 out of 10, which is a reliable pain score, but we found something discordant with his history. Like he has 2 out of 10, but he have to wake up every 2 hours. He have to wake up at night by pain. So this means maybe due to his age or whatever, but we just cannot rely on just pain score. So that's what we have to look for the indication and how to use cannabis to concordant with the patients. And right now we are looking for the contraindication and precaution. So we have to ask for more questions about hypertension. Is that controllable? Other current medications which gonna have interaction with our cannabis, and due to his aging, we have to look for his renal and hepatic function. So from our group, we have some more questions to get from him, like which I have talked already, and look for the Nabilone side effects, the abuse potential, like street cannabis, and risk of addiction, like alcohol, cigarettes, and drugs, smoking. Look for the caregiver, look for the depression or any mental disorders which going to be have in this patient, and any instrumental use like the cane. For treatment objectives of this patient, mainly should be the symptom control, which is mainly on activities. So pain is our objectives, especially during walk and sleep, and also the insomnia. And the second one, we think about the functional improvement. So our treatment plan, we should go on with the concept start slow, go slow, and we should titrate up the Nabilone a little bit for making the insomnia better. And we designed to put the balance oil, THC and CBD oil, which is titration protocol. Due to his aging, so we can assess slow titration to 5 days interval. And so day 1 to day 5, you can start with 2.5 milligrams before bed, and then another 5 days we titrate up to twice daily, and then another day we titrate up to double dose of twice daily.
Good afternoon, everybody. I'm Dr. Visit, representative from Group 4. Actually, for short, our opinion is totally the same as the Group 3. Anyway, for complete our job, So I would like to add up some questions that we don't know the things in this case. So whether or not should we taper down the dose of the gabapentin in this case when we titrate cannabinoid and it achieves its effect. The second question is is the CIPN resolve or reversible in what time it's reversible? So we start the cannabinoid and control pain of this patient. Should we waiting for and look closer to judgment to decrease the dose of the cannabinoid in the future? So that's all.
So, actually, I'm so sorry. I used to. Okay, so one aspect that we sort of overlook a bit in our presentation this morning was one precaution. It's not a contraindication, not a limitation, but it's a question that we normally ask patients within that context, which is the history of abuse. The abuse can be physical, psychological, sexual. And you will be surprised that many patients, particularly with chronic pain syndrome, but also with a cancer history, have a positive history of abuse. And that for us is a bit of a red flag, okay? We know that this patient will be a bit more difficult to treat because at the base of their condition / suffering, there is this initial PTSD, sort of like, okay, experience. So patients with PTSD generally respond better to THC. Okay? So it's something to consider and to sort of reevaluate over time to better understand how this positive finding can impact on the outcomes of our treatment. Okay? So his functional status was actually good. Psychosocially, he was very active. He was like very much involved in community work and was doing a work in relation to meditation and self-awareness. So in a sense, he kind of seemed to have sublimated, his past bad experience, So the attitude was good. And what I mentioned before, despite the patient was not sleeping well at night, was not able to walk because of the pain, he was still reporting 2 out of 10 on the pain scale. This is to say that as we have to handle with caution patients who say I'm 10 out of 10 on every items, because obviously we are exaggerating, we are sort of over-expressing, we are manifesting their suffering, which is not necessarily symptom-related, okay? So we have to overestimate a bit this sort of score, which looks quite good, because normally we consider presence of pain, with 4 or higher on the pieces, okay? But, in this case, so we really need to overestimate a bit that assessment, okay? Because we obvious. So, it was started on Nabilon at 0.25, which had some improvement in his sleep. This is to also indicate that patients that suffer from PTSD, they often respond very well to Nabilon in particular, okay? And that has been seen in veterans and, other sort of professionally wounded, people. So this is consistent with, this system. The risk of addiction or cannabis is also very low. Now, again, we had to formulate this case with your type of situation context, okay? Which is, you don't have CBD, otherwise we would have considered to use CBD, but that I will sort of explain that later. Normally, our products balanced, are, 10 of THC with a little more CBD, so 10. And we started actually to use it in morning, actually no, night. Morning because he was taking Navigon at night. And we used just once a day, then twice a day, then TA. And then start the titration by 0.1 ml, which is like 2.0 milligram THC, 3 times a day, every 3-4 days, until desired effect / symptom control. Again, this has been a bit of a case where potentially, if we didn't have Navigon at night, we would have started THC and CBD at night rather than in the morning, okay, to help with the tolerance. Because of the effect of CBD and the usefulness, we could have considered anyhow to use a combination, not just THC for this person. So, but it's obviously that, in this scenario, we could have, just increased the Navigon and, use the THC CBD during the day. So, again, it was explained that if side effects will come with increasing the dose, then we have to go back to the previously tolerated dose. And sometimes we need to go up even slower than 0.1 ml 3 times a day, and using just a drop. The drop is 0.05 ml. We know that more or less 1 ml is 20 drops, okay? So you can make the mathematics. Now, assuming that this patient was not having access to Navigon, before I make a joke, let's assume this patient comes to Thailand from Canada, okay? So what are you going to do? So in case the THC CBD would have not worked very well for his insomnia, then we could have considered to add some THC-rich oil at night. Meaning, we want to increase the ratio between THC and CBD when the patient needs the most in terms of sleep, for instance. If it was the opposite, meaning that, THC CBD was not helping very much with the pain during the day, but the patient could not increase further the 1-to-1 oil, well, we would have added some CBD. In your case, I think we would have sort of managed as best as we could by, finding potential other aspects. But this is, in theory, what you should do. I mean, if the 1-to-1 is not working at night, then you will increase the THC component. If the 1-to-1 is not working during the day, then you may have to increase the CBD, because by increasing the THC, you will also potentially increase the side effects. Let's see. Okay, so that was the, initial plan, and I think many of you have rightly said to increase the Navigon at night. Okay. In our experience, the combination of CBD-rich oil in morning and early PM with the Navigon at night is really a winning combination. We have to specify that our CBD-rich oil
that we use has a sort of sativa profile, so it's very indicated, to be used during the day. But this is what we generally do, and yeah, that's basically it. Question?
So I have a little bit questions. What is the difference of the results if we titrate up of the oil in the IV dose? I mean, twice daily or 3 times daily. I mean, if we titrate up to from before bed and then twice daily, and then we titrate up each dose of that twice daily, or we have titrated up from twice daily to 3 times daily. Any difference in or any recommendations?
So, in general, when you have the younger is the patient, the more fast is the metabolization, as you probably know. So, in some patients, the twice a day administration is not enough to cover the, the full 24 hours. And patients may say, well, I'm good during the day, but I start to have troubles early afternoon. The pain comes back. And then becomes really very painful. I need to wait until the night to take my next dose. And you have to remember that the oil still takes about 2 hours before it can reach its maximum. So it's really something that should not happen. It's a bit like what happens with a long-acting preparation. In some patients, you have to use 3 times a day rather than 2. Or change the fentanyl patch, every 2 days instead of every 3 days, You may have that condition. So obviously you have the choice at times to increase the doses rather than increase the number of administration. But in general, with a half-life of 6 to 8 hours, it's more indicated to give 3 doses before, just increasing the two doses. Let us answer your question. Yes.
Yes, so he's 72 years old, but he's not frail and he's still very active, and in the blood test, the renal and liver function are well. So we start with 3 times per day approach, but the 2 times per day, because he's 72, is a good approach too. But it's more difficult when you don't see the patient like physically, but he can have 3 doses per day. But very good comment.
Yes, we can move to the third.
Can we have the representative of the next case, please? Group 6. And Ngong.
Good afternoon. May I introduce my scenario? Mr. LC, he is 57 years old and His history is 2 years ago. He was a typical carcinoid thymus data code resection for complex thymus atypical carcinoid tumor anterior mediastinal, and he get adjuvant chemotherapy cisplatin etoposide for 4 cycles, and then he was radiation therapy at chest for 30 fraction. Then 2018, May 2018, she met seen recurrent cancer advanced stage 4 pericardial metastasis, gastrohepatomegaly concern to metastasis. Author past history, no drug allergy, no history for opioid use, no antidepressant, and he stopped smoking for 15 years ago, and functional cast for ECOX-1. Current mate, he has a finiter since February 2018, and Nabilone 0.5 mg for AM and 1 mg for HS since April 2018. There no problem for pain, EZ score for 0, and presence for insomnia, anorexia EZ score for 10, fatigue 8, and anxiety 2. No contraindication for Nabilone use. Microphone management, the first, we can search for collectible cause for this patient, and then we assessment for psychosocial problem. And then the main problem in this case, we think about fatigue, anorexia, and insomnia. We think we can relieve by THC use. For one, if we have Nabilone use, we can use from the current dose 1.5 mg per day, 0.5 AM and 1 for HS. We get 4 go slow and stay low. We have to use Nabilone increased dose for 1 mg AM and 1.5 mg for HS. If in Thailand we know for Nabilone, we change to twice dose for oil. The one balanced THC CBD 7.5 mg for AM and pure THC oil 15 for HS. Thank you.
And for my group, mostly are the same with her group. Just my group decided to increase only the THC, not use a combination, because we don't think we prefer to use the single agent to avoid the confusion for the patient. And another issue is the drug interaction between Nabilone and Afinitor. According to Nabilone can increase the Nabilone or THC can increase the Afinitor level. So it might, all the symptoms of this patient might come from Afinitor side effect. Therefore, increased Nabilone might increase the Afinitor side effect. So we have to monitor all of them. If we increase Nabilone and all the symptoms go up and up, that might mean that Nabilone cause Afinitor more toxicity.
Very good. So very, okay. I didn't have time to look at my PowerPoint, but so very important comments. Certainly, we need to look always at reversible causes.
this is that the Venabilon was not really doing a lot, okay, for this patient, because when you are going to that dose and you don't really see good signs, just to increase it, I don't think will lead to a better effect. You are right. There might be also interaction, pharmacokinetic, and those interaction becomes more evident with higher dose. So we actually decided to try another combination which is quite effective for insomnia, which is combining CBD to a THC with CBD, so a balanced formulation. And this is, in our experience, the second best intervention for insomnia. The first one would be Nabilon, but 1 milligram of Nabilon was really not doing a lot. The second would be the balanced combination, THC plus CBD. Now, the type of symptom that he was having were quite incidental, in the sense that he was having nausea, particularly looking at food. And that was also giving him problem with appetite. So he was nauseous seeing food, that would have killed his appetite. Okay? So, the Nabilon itself was not enough. So what we decided is to start using an inhalation, product, which was a THC sativa type, okay, that the patient was using just 5 minutes before, before eating. So here you see our combination, where we have again started with a relatively small dose of oil, and again, we sort of preferred to just use this at night and some dry cannabis during the day. Now, if you didn't have the dry cannabis, probably some oil, 1-to-1, could have been also used in the morning. And sort of to replace, the Nabilon. But, the type of situation was really situational, meaning if the patient would have been nauseous all the day, it would have been probably better to use the 1-to-1 oil, okay? Or potentially even the THC oil. But again, this was very active, was still working at the time that we saw him. So he was concerned, and he had his own business, okay? So he really need to be in control. So the ability to have a short, fast-acting, short-lasting preparation allows patients to be also a bit more able to function during the day, because the effect will be very limited and very focused. So that is why we use that approach. Any question?
Confusing. Because in my understanding, THC is good for anorexia and insomnia. And in this case, they use Nabilon for 1.5 milligram, and it doesn't work very well. So instead of increase the dose of Nabilon, you're going to add on CBD. Why?
Yes. I'm not sure if we have documented in the past if it was if he had tried to increase the Nabilon as well. But Did we start with Nabilon as? So we
So with the Nabilon, we can explore the THC effect that seems in this patient to not work as well. So that's why we change it to a one-to-one oil at night and to use dried cannabis because it was more only aversion with food. It was when he see food, he doesn't want to eat it. So we can stimulate like with a short-acting THC during the day the appetite and control the nausea because it was not ongoing. And for the sleep and that's why we explore that the THC was not enough effective for this patient.
This is the art. The art.
At which dose that you think that is not going to work? At which point?
You know, like I think that there was some evidence that even increasing, you know, the Nabilon, there was not really an effect associated. The other thing could have been that if it was trying to increase the Nabilon, then that would have impaired him functioning during the day. Okay. The other thing you can notice that despite taking 1 milligram, that he was not able to sleep. So you need to change a bit strategy. You need to use an alternative, and that is what we do. You know, there is nothing that can sort of say, oh, this is not following what we expect, so it's not a cannabis candidate. You need to be creative, and you need to start, you know, and you see that the Nabilon seems to be helping in the past, but you know, but not anymore, because there was an initial response to it. Now, it could have been a tolerance induced to Nabilon. That could have been also a you know, an alternative, but we just wanted to explore, you know, that a different approach, and then we've seen the follow-up. What was the, you know, the outcome?
When you said we discontinued the Nabilon and change to the natural products, the oil, do we have to calculate the equivalent THC on the switching?
So, very good point. It's similar to what happens when you are rotating from an opioid to another one. There is what we call incomplete cross tolerance. So not necessarily, you know, you have to use the same dose, equivalent dose. So we started at 5 of equivalent of THC, and he was taking 10, you know, because 1 milligram of Nabilon is equivalent to 10. But you have to consider several factors. 1, incomplete cross tolerance. 2, you are giving a natural product that has 150 different molecules inside. So it's different than just a single molecule. So the effect that you're getting, as we were explaining yesterday, is called entourage effect, which is eventually more effective than just the stimulation of a CB1 receptor as obtained by Nabilon.
So what do you suggest, like decrease with 10% or just try it slow?
Yes, I mean, probably, you know, if it was not on Nabilon, we would start at a 0.1, you know, like 2.5 milligram of THC. But it was already exposed to Nabilon,
So we started at 5 milligram of THC, so which is already a higher dose than. Then it's a bit, about, understanding what is the effect, what would be, the contraindication, the renal function, the liver function. If this was otherwise a healthy individual, okay, so, we didn't have particular precaution. But again, we sort of decided that that was the way to take, and to start again with he was a chronically insomniac. So we were not expecting, or we were not told him that the next day he would have been sleeping better. Okay, so it's always nice to start low, not to obtain tolerance to side effects first.
So do you have any more discussions for this case? So if not, then at the moment, maybe we can go on to the last case. So can we have the representatives from group 7 and 8, please?
Group 8. This is for Mr. LB, male 40 years old, rectal carcinoma with lung metastasis. He has received treatment for complete since 2016 until now. Now he has chemotherapy and also radiation and cancer surgery for primary site and metastatic site. Currently on Avastin and CW. On 2nd January, blood test was okay, and also CT abdomen was done on 4th. It's okay. We can't recognize the tumor. Transferred by oncology team. He has irrelevant medical history and he has allergy to dexamethasone and hay. Now he take prochlorperazine, PRN for nausea vomiting. Now his symptom is he still have pain, nociceptive visceral pain, continuous asthma, and insomnia. Now he take THC tincture from internet. The result almost completely relieved. He take this for relaxation and he can sleep all night. For the anxiety, the intensity is 410 and fatigue for 15. ECOG score 2 to 1. Now for the assessment. He is young, 42 is young, right? Healthy and good psychosocial status, normal daily life with some limitation due to fatigue. Previous use of cannabis or THC tincture from internet since diagnosed, but a good result. Now, no contraindication for cannabis use, and he has low potential to addiction. At first, we just ask for like a mental status or social. We have some disease or condition that, like a medical condition, he has no. For treatment objectives, used for symptom control and functional improvement. Treatment agreement with the patient. Okay. He must we inform him that appropriate personalized pharmacological treatment should be applied, but he denied for more medication, like opioid something. And now we ask him for commitment, stop use the street product because we want better or for assurance that for our medication. And we choose the THC for the first choice. And prioritization, because we don't know the exact concentration of the tissue from street products, so we go soon. But assume that he used this street product for 2 years or more, so maybe he can tolerate. But we cannot sure that how concentration. So we start THC at night. And I make sure that he has no side effect during daytime because he still can work. And then after that, we monitoring for the side effect, insomnia, anxiety, and maybe oversedation because he still work. Remember.